Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Michael Madaio on PrEP and PEP strategies for HIV. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold any questions until that time, or you can place them in the chat function. And now I'd like to give a quick introduction to our speaker today. Dr. Michael Madaio is an attending physician at Midcoast Hospital responsible for running an inpatient infectious disease consultation service for a 100-bed community hospital. He also runs an outpatient infectious disease office handling referrals from providers throughout the coastal Maine regions. Dr. Madaio serves as the medical director for both infection prevention and antimicrobial stewardship. And with that, I will hand it off to Dr. Madaio for our presentation. Thank you all for being here today.
Great. Well, thanks for having me, Bethany. So yes, as Bethany said, we're going to be talking about PrEP and PEP strategies for HIV, and we're also going to talk a little bit about other vaccine-preventable sexually transmitted infections with the goal of educating you guys about how we can cut down on both the number of cases of HIV, but also other sexually transmitted infections. Without further ado, my disclosure slide, like Bethany said, I have no financial disclosures relevant to this presentation. I will say that most of the slides are adapted from the National HIV PrEP curriculum, which is a great resource if you're looking to do additional training on HIV PrEP. The link that is right there. It's hosted by the University of Washington with national funds. And it's actually a really great training program, really interactive, and you can do it on your own time. So I highly recommend it if you want additional training, like with practice questions and whatnot. As for objectives today, we're obviously going to cover a little bit the body of evidence supporting PrEP and PEP and why this is an important issue and something we should be providing to as many people as possible. We're going to talk about the various medication regimens that are available for both PEP and PrEP and how to monitor and manage patients that are on those prophylactics. We're going to talk about resources, financial resources that is, for coverage of PEP and PrEP, specifically for underinsured or uninsured patients. And then, like I said at the beginning, also identify some other vaccine-preventable sexually transmitted infections. So some definitions, just I don't know everyone's backgrounds, just so that we're all kind of on the same page, but HIV obviously stands for human immunodeficiency virus. That's the pathogen that causes AIDS, which is the acquired immunodeficiency syndrome. A technical note, but important to know, is that all patients with AIDS have HIV, but not all patients with HIV have AIDS. In fact, with antiretrovirals today, there are many people that have HIV but have never had AIDS and will never get AIDS. PrEP stands for pre-exposure prophylaxis. That's something that someone takes prior to a potentially risky sexual encounter to prevent the acquisition of HIV. And PEP is post-exposure prophylaxis, which is something someone takes after a potential exposure to HIV. HAART, or ART, stands for antiretroviral therapy. We've dropped the HA in the last decade. That was really invented in the early 2000s to try to publicize and create a good kind of a layperson understanding of how highly active these medications were. But given that they're all highly active and it's a little bit of a silly acronym, that has been kind of left behind. And we more commonly refer to medications for HIV as being ART, or antiretroviral therapy. So first off, I want to talk a little bit about the need for HIV PrEP. Like, why is this important? Well, it's important because of a number of reasons. One is that HIV infections, since the AIDS epidemic began in the 80s, have not significantly decreased, despite all the available medications we have and how effective PrEP is. In fact, there's about 32,000 new HIV cases each year. Which really just shouldn't happen. Additionally, HIV PrEP is highly effective. It's about 90% to 99% effective at preventing sexual acquisition of HIV. And although there's less studies in people who inject drugs, we know that at least it's 70% effective in that population. It's also very well tolerated, and these medications don't have a lot of side effects. As I get to later, they're pretty much always covered by insurance. Unfortunately, despite how effective the medications are, HIV PrEP is really underutilized. Some estimates say between only 1 in 3 or 1 in 5 people that really should be on PrEP are on PrEP. And so a lot of people just aren't being protected. And then lastly, I kind of allude to this, most insurance plans and Medicaid programs cover HIV PrEP and PEP. So usually cost is not an issue. This is just a little bit of old data, comes from the CDC about kind of overall PrEP coverage from 2017 to 2022. That is the percentage of people that they estimate need PrEP based on their sexual activity, and then a number of them actually prescribed a PrEP medication. In 2022, that was about 35%. And the national 2025 ending the HIV epidemic goal is 50%. So you can understand that there's still a ways to go, and 2025 is right around the corner. Unlikely we'll meet that, but it just kind of underlines how important this really is. So going into the science of PrEP, like how did we get to this point? I don't know why that disappeared. Okay, there we go. Essentially, there's been a number of scientific studies over the past decade that have enrolled over 25,000 participants from around the world and conclusively answered that HIV PrEP is both safe and effective. This started with like the Caprisa study in 2010. It then bridged into the Voice and the iPrex and then the FemPrep and the Partners Prep. These were all different studies that we'll briefly cover on the next slide that showed that this was really an effective strategy for HIV prevention. And that led to Truvada being approved by the FDA as the first medication for PrEP in 2012. In terms of efficacy, we know from these studies that, like I said before, it's about 90 to 99% effective when the medication is taken as prescribed. Fewer studies have looked at transmission via injection, drug use, or needle sharing, but the ones that have been done show that the efficacy appears to exceed 70%. So in essence, the science is settled, and there really is no question about whether or not this is an effective medication, a series of effective medications for HIV prevention. Going really quickly through the studies, I don't want to spend too much time on this, but the iPrex I mentioned was a major landmark study in 2012 that looked at the use of Truvada for cisgendered men and transgender women who have sex with men. And they found that compared to placebo, there was about a 50% or technically a 44% reduction in HIV incidence, which was statistically significant. And so this really paved the way for Truvada being approved by the FDA as a PrEP medication. Other studies include the Hypergay study. This was done in France that looked at on-demand Truvada. So typically how we prescribe Truvada, which we'll get to later, is as a daily medication the person takes all the time. Some patients don't do as well with that. So what this study looked at was what happens if a patient just kind of takes it on demand in what's called a 2-1-1 method, meaning they take 2 pills before the sexual encounter and then 1 pill each day for the 2 days following. And that found that although it was not quite as effective as daily Truvada, it was still really effective, about 86% reduction in HIV incidence. Cabotegravir, which we'll talk about later, is a long-acting injectable medication that can be used to prevent HIV. This was studied in the HPTN 83 study just in 2021, which led to its FDA approval for prevention and showed similarly that a long-acting injectable also substantially reduces the risk of HIV acquisition, even compared to Truvada. It was actually superior to Truvada in this sense, probably because people don't have to remember to take a pill every day, right? It's instead dosed every 1 to 2 months. And then the last study we'll briefly talk about is the Bangkok TDF. This is one of the biggest studies that looked at HIV negative people who are not necessarily MSM or have any sort of sexual risk factors, but were injection drug users. It was based out of Bangkok and several other places in Southeast Asia. They randomized people to either getting Truvada, 1 tablet daily, or placebo, and found again that there was a pretty significant, about a 50% reduction in HIV incidence in the Truvada group compared to placebo. And as I mentioned, still not as effective overall as with sexually transmitted HIV, but it was a smaller study and there were difficulties with adherence to the study regimen because of the population. So that might have impaired the efficacy, but still showed that it was probably a highly effective strategy for people who inject drugs as well. Despite all this evidence that PrEP is so effective, there is a lot of stigma about PrEP that leads to decreased access. And that's due to a complex interplay of social determinants of health, right? Which we can't really fully elaborate today in the span of this meeting. But an example of this would be just in recent years, Black Americans, despite accounting for 40% of new HIV infections in the past year, only account for 14% of people taking PrEP. So clearly they're a population that's not being adequately reached with the PrEP that we have available, which is a shame, right? We know that there's disparities in access related to insurance coverage, but also there's an unequal distribution of clinics providing PrEP. Like in a perfect world, every clinician could prescribe PrEP, much like we prescribe statins for people with high cholesterol to prevent heart disease. But unfortunately, most primary care providers, most providers in general are unfamiliar with PrEP and don't think to assess someone's risk for HIV and don't offer it. Additionally, there can be obstacles in terms of the patient presenting for and asking for the PrEP. That can involve an individual perception that their HIV risk is too low, right? They might think that what they're doing sexually or with injection drug use is not a risk factor for HIV. For example, a lot of people with injection drug use don't really think you can get HIV from injection drug use when you absolutely can, right? Other people are unaware of the options for HIV PrEP. Like a lot of people think there's only the daily pill that you have to take. They're not aware of the 2-on-1 method or the PrEP on demand or the long-acting injectable, for example. So they don't think to bring it up with a healthcare provider because they don't think a daily pill will work for them, right? Other people don't have access to a knowledgeable HIV PrEP provider, like I got to in the last slide. Maybe their PCP is not gender affirming or is not someone that's comfortable providing PrEP. They live in a rural area, and so they're unable to actually find a provider that will prescribe them PrEP, even if they want it. Other people are just not comfortable talking to their healthcare provider about PrEP because maybe they're not open about their sexuality or their injection drug use. And so they're not going to ask the provider to prescribe them medication to protect them. And then kind of last but not least, some people are unwilling to take the HIV PrEP, either because, again, they don't want to take a pill every day, they're not aware that there's other means of HIV PrEP, or they're concerned about potential side effects of the PrEP or the perceived costs of the medication. And those costs, the financial concerns could include not just the cost of the medication, but also the costs of going to a clinic for routine follow-up of the PrEP and the cost of laboratory monitoring, right? So for someone that has minimal insurance or no insurance, that can sound like a very costly thing. And lastly, some of these patients, really unfortunately and sadly, have significant mistrust in the health system because of past traumatic experiences with healthcare, whether it be discrimination because of their sexual identity or their gender identity, or, for example, Black and African American communities in rural areas who were, experimented on with the Tuskegee experiments, right? And so are reluctant to necessarily take a pill that's being offered to them by a healthcare provider. When we talk about the HIV care continuum, what we mean is that in order to prevent HIV, there's a kind of a linked continuum that has to happen. For people with HIV, they have to first be diagnosed with HIV. They have to be connected to care for the HIV. They have to get the care, get the medication, and they have to keep taking the medication and stay retained in care in order to ultimately achieve the final link, which is suppression of the viral infection. And with PrEP, it's a similar situation. We need to find people who are at risk for infection, identify them accurately, identify them as a PrEP candidate, get them interested in PrEP, link them to a PrEP program, start them on PrEP, keep them on PrEP, and then to achieve that final goal of persistent evasion of HIV infection, right? So because this is such a multi-step process, people are lost along the lines all the time. And that's what we really need to do better as healthcare providers, to see where in the link can we fit to help people get to that endpoint better. So what can we do to overcome PrEP stigma? Well, it's not easy, and again, we won't be able to entirely impact this in this lecture, but taking a stigma-informed and trauma-informed approach to HIV preventive care is key. What does that mean? So there's trainings that go over trauma-informed approaches, but essentially that means that you should be of a mindset where you understand that people are approaching this, patients that is, with a past history of stigma and trauma, and recognize that and validate that and explain to patients, your strategy for getting around that. Can also use inclusive, non-stigmatizing messaging. This is really important. Like when it comes to surveys in doctors' offices, having an option on your intake form to include non-binary gender options is inclusive and encourages patients to be a little more open and willing to try things with you. Referring to things, like referring to someone as being gay or LGBT as opposed to someone being a homosexual, or things like that. Language really matters. Another thing is normalizing HIV screening and talking about PrEP. This is something that probably should happen with all people. In fact, the USPTF recommends that all adults in the United States, regardless of any factor, should get screened for HIV at least once in their life. Yet I know as an HIV provider and infectious disease doctor that the vast majority of patients I see have never had an HIV test. And when you suggest an HIV test, they look at you like, what? Why would you do that? You have to explain to them this is a routine part of care and something that actually should be built into just general medical care. Similar to PrEP, we should be discussing PrEP of a variety of types, including the vaccines I'm going to talk about, but also HIV PrEP to everyone that's sexually active, and decide with each patient if it's something appropriate for them or not appropriate for them. Additionally, as I alluded to before, integrating more HIV PrEP into primary care settings is crucial. Ideally, if someone is looking for PrEP, they should not have to see a primary care provider and then be referred to a specialist just to get the PrEP. Ideally, they should be able to go to the primary care provider who can then provide the PrEP. Patients generally actually prefer to get most of their care from a primary care provider rather than seeing a number of specialists for all sorts of different things. And then kind of lastly, utilizing a community-informed approach to HIV PrEP messaging. What this bullet point means is that if you're going to think about how to kind of increase PrEP utilization in your communities, you should think about tapping people in your community that would need the PrEP. So sexual minorities, men who have sex with men, injection drug users, and see what do they think about the messaging you use? How would they want to have it advertised to them or suggested to them? This is something we don't do enough of in healthcare, is actually have patients contribute to medical or systems decision making, when really they're the key stakeholder in everything we do, and we really should include them in our decisions. So changing gears a little bit into the actual PrEP regimens and who should be offered PrEP. Well, so there was an update to the CDC and the USPTF guidelines in 2021, not that new, that actually recommended that all sexually active adults and adolescents should receive information about PrEP, regardless of what type of sexual activity that was. Again, a lot of people's perception is that this is only MSM who benefit from HIV PrEP, but in fact, heterosexual people get HIV all the time and also can benefit from PrEP in certain situations. Especially important are people that have a history of sexually transmitted infections, for example, gonorrhea and chlamydia, people who have multiple sexual partners, people with inconsistent condom use, certainly people in a relationship with someone with HIV. That's called a serodiscordant couple. People who are kind of sexually active in a high HIV prevalent area or network, people who participate in transactional or sometimes called survival sex, people who inject drugs, particularly those who share needles or injection equipment. And then lastly, people asking for PrEP, which some people will ask for PrEP and don't have any of these criteria, and a provider should never discourage them from PrEP. If a patient is asking for the PrEP, they probably are aware of some risk factor that is not really quantifiable, and it is reasonable to give them the PrEP. It's also important to note that protection. When we talk about protection, when it comes to sex, a lot of people think about condoms, right? Protection is not always condoms, right? There's a number of ways you can protect yourself in sexual encounters. So condoms can help with a number of sexually transmitted infections, such as they obviously help with pregnancy. They can help with prevention of transmitted infections like HIV and gonorrhea and chlamydia. But there's many other ways we can help protect people. That can be like with birth control for pregnancy, doxycycline post-exposure prophylaxis, which we won't talk about today, but that's another strategy for preventing things like syphilis, gonorrhea, and chlamydia. HIV, obviously, PrEP and PEP. And then HPV, which we'll talk very briefly about at the end. There's a highly effective vaccine, right? So really, we need a multimodal protection strategy for people who have sexual risk factors or just sexually active in general to prevent them from having any sort of complications, such as an infection from that sexual activity. So then going into the PrEP medications. So there's three basic medications that we should talk about that are all FDA approved for pre-exposure prophylaxis. The first, and kind of the standard in most situations, is called tenofovir DF emtricitabine. So it's a combination of two medications, the tenofovir, specifically the older disoproxil fumarate, that's what the DF stands for, and emtricitabine. Those two medications together, branded by Gilead, is called Truvada. It's sometimes also abbreviated TDF-FTC. Most people just call this Truvada. So Truvada is, like I said, it has an FDA indication for HIV PrEP. It can be used along with other drugs to treat HIV, but used alone, it's only used for prevention of HIV. That's important. It's recommended for anyone that's sexually active and has risk for HIV, which is essentially anyone that's sexually active. Some important things that are key to the indication is that prior to starting any sort of PrEP for HIV, someone needs to have a negative HIV test. Why is that important? So, like I said, Truvada can be used as part of an HIV regimen for treatment, but it is not effective alone for treatment. So, if someone is presenting asking for PrEP and they actually have HIV and they're not aware of it, giving them just Truvada does not help them. It actually selects for resistant HIV that can then be more difficult to treat. So, it's critical that everyone that started on PrEP has an HIV test prior to starting. And that's just your typical fourth generation antigen antibody test. Yeah. And then the kind of also included in that paragraph is that although it's not FDA approved for the prevention of HIV through injection drug use, it is recommended by the CDC, and based on those studies we talked about. The dosing is really simple. It's a single tablet once daily, really not hard to remember. Again, there is the 2-1-1 method, which we won't talk a lot about, but that's the on-demand method. That's where someone takes two Truvada pills at least 2 hours before a sexual encounter that would be risky, up to 24 hours before that sexual encounter. And then they take one pill the day after the sexual encounter, and then one pill 2 days after the sexual encounter. So hence 2-1-1. That can be kind of confusing for a lot of providers and also for a lot of patients. And so that's why it's generally not recommended unless the person can't tolerate the once daily regimen, they're forgetting pills, etc., or don't want to take a daily regimen. They can potentially do an on-demand regimen. The formulation it's an oral tablet, 2-drug fixed dose. There's really not a whole lot of information in this bullet point. There's generics available. Those are usually much cheaper. Often those are what are covered by insurance. So if a patient really prefers brand name Truvada, they might not be able to get coverage for it, but there's no obviously benefit of brand name over the generic. There's no specific food requirement. Someone can take this on empty or full stomach. It doesn't really interact with most other common medications. There is a warning on the medication that it can't be used for people with chronic kidney disease, specifically people with an estimated creatinine clearance of less than 60. And why is that? Well, that's because tenofovir disoproxil fumarate, or tenofovir DF, has been associated with nephrotoxicity, particularly when it's used for a very, very long time. It has also been associated with decreased bone mineral density, again, mainly in people who are treated for a very, very long time. These risks are thought to be very small, and so generally are still acceptable for someone that's going to go on Truvada for PrEP. The next antiretroviral we have to talk about when it comes to PrEP is Descovy, which is tenofovir alafenamide along with emtricitabine. So it's almost the same medication as Truvada. It's essentially just a newer formulation of tenofovir. Again, same exact indication as with Truvada. Again, you need a negative HIV test prior to starting, like you would for every PrEP. One little caveat here is that Descovy, or tenofovir alafenamide emtricitabine, is not actually approved for receptive vaginal or insertive vaginal sex. And that's because it hasn't been extensively studied in that population. And there are historically some concerns that the newer formulation of tenofovir may not get therapeutic concentrations in the vaginal tissue. Um, I think more studies will come out and eventually this will be approved. But as of right now, if you have a patient that's having receptive vaginal or insertive vaginal sex, you should know that Descovy is generally advised against, and Truvada would be the preferred agent in that situation. Again, dosing is pretty simple. It's just one tablet once daily. The formulation is essentially the same, just a slightly different dosing of the tenofovir because it's a slightly different chemical. It can be taken with and without food. In persons with renal impairment, so the main benefit of this tenofovir alafenamide is it has not been shown to cause significant nephrotoxicity like the tenofovir DF. And so it can actually be used in people with chronic kidney disease as long as their estimated creatinine clearance is above 30. So it's much more generous in that regard. It also doesn't cause the bone mineral density issues that tenofovir DF does. However, it does have some potential long-term side effects that are thought to be not as serious, but depending on how you look at it, could be. That would be weight gain and also worsening blood cholesterol levels. That's something that's been a lot of study in people living with HIV because tenofovir in particular is a backbone of many HIV regimens, and there has been a signal in that population of people that they have an increased rate of heart disease. And whether that's completely related to the tenofovir or other factors, it's not totally clear. There's definitely other factors that contribute, but that's something to think about. The last HIV PrEP medication that's FDA approved is long-acting injectable cabotegravir, which is a brand named Apretude. Similar to Truvada and Descovy, this is indicated to prevent HIV infection. Someone also does need an HIV test before starting it, of course. It's dosed very differently because it's not a pill, it's an injection. So these are injections you get in a doctor's office because they're injected into the gluteal muscles. And it's a bit of a difficult location for a patient to inject themselves with. And it's also a fairly large volume and a big needle, and it wouldn't be terribly comfortable for some patients to do themselves. Essentially, it's given as a one injection or two injections 1 month apart for the first 2 months, and then every 2 months thereafter. So obviously, the main benefit here is the person doesn't have to take a pill every day. They don't even have to take it when they're having a sexual encounter. As long as they got their cabotegravir dose in the last 2 months, it's in their system preventing HIV, which is great for a lot of patients. Some patients that have a lot of drug intolerances may benefit from having an oral lead-in with oral cabotegravir. That's just because you wouldn't want to give someone a long-acting depot injection of cabotegravir and then have them have some, negative response to it. It'd be very unusual to have anaphylaxis, and actually the FDA no longer requires an oral lead-in, but something providers can consider if a patient is concerned about getting a depot injection before taking it. The only caveat there is you have to reach out to the manufacturer, which is Viv, and then they have to essentially send the cabotegravir to your office as an order because it's not available at routine pharmacies as a normal medication that people take for PrEP, but it is technically available for that use. Again, we kind of already covered this. It's an injectable medication. This is injected into the gluteal region. Most patients tolerate this very well, and of all the patients I have on an injectable antiretrovirals, it's very rare for a patient to discontinue the injection because of pain, but pain at the injection site is a notable side effect. No food restrictions, obviously. There's no restriction on people with any degree of renal insufficiency. So people could have end-stage renal disease, for example, and they could still technically get cabotegravir. Again, side effects are mainly injection site pain that usually resolves within a few days. I usually counsel patients after the injection to take an anti-inflammatory like NSAIDs plus or minus Tylenol to help with that inflammation because you are essentially injecting 3 mLs of fluid into the gluteal muscle, and you're going to get expansion of that muscle and a pocket forming, and that can be pro-inflammatory and painful. particularly as people lay on one side when they're sleeping in bed, because we actually inject it at the ventral gluteal site. So kind of in the almost the side of the person's back, not so much the buttock itself. Um, Other kind of specific concerns about cabotegravir that people should be to know about if you're going to be prescribing this is it's a long-acting injectable, right? So it at least lasts 2 months and provides really good protection for those 2 months, but it doesn't just suddenly disappear after 2 months. It actually remains in the bloodstream at a detectable level for up to 12 months. The problem, though, is around month 5 or month 4, it drops to such a low level that it's not really effective anymore. But if someone gets exposed to HIV during that period of time, it can essentially select for resistance because it's essentially not enough of the integrase inhibitor, which is the type of medication cabotegravir is, to actually fight off or prevent HIV infection, but it kind of pumps the brakes, so to speak, and gets HIV to develop resistance. And resistance to integrase inhibitors can be quite devastating to HIV treatment, as they typically form the backbone of most of the regimens for HIV treatment today. So as a result of that, I don't know why this is not, I guess it's on the next slide, but essentially as a result of that, someone that's going to go on cabotegravir has to be committed to getting those injections. And if they stop getting those injections for whatever reason, for example, the pain becomes too unbearable, they decide it's not right for them, for example, they have to stay on an oral PrEP medication for a year after stopping that to make sure that they're adequately covered during that cabotegravir tail, we call it, to prevent any selection of resistant HIV that they could potentially essentially be exposed to if they weren't taking an oral PrEP agent. Other concerns about the cabotegravir would be cost. This is covered by Maine Care without a prior auth, which is amazing. Many other insurers are starting to cover it, but they're in various stages of approval as this is only about a 3-year-old med. I anticipate it will get more and more approval as time goes on, but sometimes you do run into issues, certainly for at least requiring a prior auth. Some insurances want to see that the person was trialed on an oral PrEP agent. But I would say most of the time we don't have major problems with this. Another kind of major concern that I think probably most of you will understand is that there's increased clinic workload. So you need to schedule these injections. They have to come back every 2 months. Someone has to actually inject the medication. That can be a nurse or a provider, but it requires a little bit of additional training. It's all kind of detailed in the packet that the medication comes in, and it's actually very straightforward. For most nurses, it's going to be similar to like giving a B12 injection. It's just slightly more fluid and a slightly bigger needle, but generally it's not something difficult for an RN to be able to provide. But it does require you to kind of build that workflow in your clinic. And we do see a lot of people referred to infectious disease specialty clinics, specifically requesting cabotegravir because, of course, we have a little better of an ability to accommodate that. But I think, again, in the next decade or so, it'd be nice to see more cabotegravir used for PrEP outside of specialty clinics. In terms of prescribing and monitoring, so you have someone that you prescribe PrEP, they had a negative HIV test prior to starting it. What do you need to do for follow-up? So every 3 months, you need to get another HIV test. And that's not because we suspect the Truvada or the Descovy or the cabotegravir won't work, but we just know that some patients don't adhere to the therapy very well. And if they stop taking it and have a sexual encounter where they acquire HIV, they can potentially get infected with HIV. And then, as we discussed earlier, if they keep taking the Truvada, that won't treat the HIV, it will just select for resistance. So the idea with the every 3 months testing is that you catch it early and then can transition that person to treatment antiretrovirals or referral to an HIV specialist prior to that happening. You also should assess them at every 3 months for sexually transmitted infections. If it's a woman of childbearing age or someone that is capable of becoming pregnant, you should consider pregnancy testing. Obviously, you're going to be assessing for side effects, adherence, how their HIV acquisition risk behaviors are changing, providing ongoing counseling regarding risk reduction. So again, protection is multimodal, should never be just PrEP, but things like condoms and birth control and all the other kind of things or syringe service programs for people who inject, right? All those sort of wraparound services that help reduce the risk should constantly be provided in addition to the PrEP. You can also consider STD testing at an every 3 month interval as well, because obviously HIV PrEP isn't going to prevent like gonorrhea or chlamydia or syphilis. Every 6 months, though, you absolutely should do STD testing, and then you should also get basic chemistries that look at creatinine clearance. This is less of a factor for the Descovy and the cabotegravir, of course. Still technically recommended, but certainly important for people on Truvada because of that small risk of nephrotoxicity. And then every 12 months, the guidelines suggest evaluating the need for ongoing PrEP. That involves looking at how the person's tolerating it, how they're adhering to it, and how has their behavior changed. Most people aren't going to need lifelong HIV PrEP as their life changes as they go through aging. Some people will need it, and it just is a year by year assessment and talking to the patient, what has changed in the last year? Do you think you still need this medication? If so, that's totally fine. Or, are you in a place right now where you're really, maybe you're not having sex anymore, or you're in a monogamous relationship that you feel really safe in, etc. And those might be indications to stop or pause PrEP. People can also always go back on PrEP, right? They can stop for a few months and then maybe their sexual activity picks up again and they want to restart. That's also totally fine. For cabotegravir only, I might have misspoke on the last slide. I said for all the PrEP agents, we do every 3 month HIV testing. For cabotegravir specifically, it's every 2 months. That's just the way we're studied. And we actually use an HIV PCR test as opposed to the standard 4th-generation assay. Again, just the way we're studied, and it's a slightly more sensitive test. Ideally, you can combine the injection appointments with the visit for labs, since they're both going to be every 2 months. As all the other labs like STD testing, the basic metabolic panels, those sorts of things can still be done every 4 to 6 months. One other thing to note about the dosing for the cabotegravir is there is a little bit of wiggle room on the dosing. So, for example, someone is due on January 6th for their second or their next dose of cabotegravir. Usually about a week before and after, so like January 1st to January 12th or something, that would still be safe to give that person that shot. And so it's, helpful to know that. In fact, if you end up giving cabotegravir in your clinic, you can go on the ViiV website and they have a tool that you can use where you plug in the person's first dose of the cabotegravir and it will plot out a year's worth of dates with those windows of time. And it's kind of useful to have that in the patient's chart so that if they call and say, look, I need to cancel this appointment, you know exactly how much wiggle room you can give the patient in terms of rescheduling. And then again, as I said kind of a few slides ago with cabotegravir, if for some reason they stop the cabotegravir, they need to take an oral PrEP, Descovy or Truvada, for 12 months approximately after discontinuing the Apretude, unless they have absolutely no HIV risk, which is hard to assess, but that would be like someone that's absolutely having no sexual activity and no injection drug use and has no conceivable way of getting HIV. They can potentially just let the cabotegravir ride out in their system. Lastly, in terms of PrEP, there's one new agent that is in the pipeline and will probably get approved sometime in spring 2025, and that's lenacapavir. This is also an HIV and also an injectable medication. It was actually originally intended for treatment of experienced HIV patients, that is, patients who have highly resistant HIV and need another agent, because lenacapavir has a unique mechanism of action that's different from every other antiretroviral. Unfortunately, it needs to be paired with oral medications, and so for treatment of HIV, it hasn't really caught on, I would say. But what has caught on is it's a very long-acting injectable that lasts about 6 months. And the PURPOSE 2 trial that happened this past spring compared this twice yearly PrEP, injectable PrEP, to oral PrEP and found that it was superior. Mainly, again, probably because people don't have to remember to take a pill. And so that has, actually, that study was essentially the details of that, there were 2 incident cases of HIV in over 2,000 people. So that's an infinitesimally small risk of HIV, about a tenth of a person per 100 person years, compared to the Truvada arm that had about 1 person per 100,000 or per 100 person years. So a huge reduction. Of course, this made waves when it came out, because wouldn't it be great if we could even space those injections out to even further, every 6 months or just twice a year. So the manufacturer of lenacapavir has submitted for FDA approval. Like I said, we anticipate that probably by spring or summer of 2025, this will get FDA approval and be another tool in the arsenal. So then shifting gears from HIV PrEP to HIV PEP. So this is post-exposure HIV prophylaxis. And we're going to specifically focus on non-occupational post-exposure prophylaxis, which isn't really a whole lot different from occupational. This is people who have a sexual encounter, for example, maybe they were raped or assaulted, or they just had a sexual encounter and then the next morning said, "Oh, you know what? I kind of, I regret doing that, and I feel like I need to protect myself," or something of those natures. If these people get started on antiretroviral therapy within 72 hours of the exposure, that's a pretty hard rule. The sooner the better. There's significant evidence that that will prevent the acquisition of HIV. And that's essentially the way, because of the way HIV infects the human cells. If you leave it in the system for too long, it will integrate itself into the host genome and essentially be unremovable. But if you catch it very early, it can be totally eradicated. And so the way this works, this is a little risk assessment diagram. Essentially, as long as someone had a quote substantial risk for HIV acquisition, and it's been those less than or equal to 72 hours, and you don't know that the person has HIV, or you know they have HIV, you should pretty much give them PEP. This diagram says it's a case-by-case determination if the status is unknown. And I'll tell you that most people I talk to would rather take the PrEP than not if the status is unknown. So for example, someone that had a sexual assault might not know the status of their assailant. They probably still want to be protected against HIV and will take the PEP to prevent that, right? But it's not technically like a hard and fast, they must take it. Some examples of substantial risk. So obviously any sexual encounter that involves vagina, penis, rectum, the mucosal membranes, body fluids going into the eyes, the mouth, etc. Non-intact skin, so injection drug use, percutaneous contact, body fluids like blood, semen, vaginal secretions, those sorts of things. Those are all substantial risk factors for HIV. What's notable is that there's certain things that are not a significant risk factor for HIV, and it's important to counsel patients about this, because if that's the case, we don't recommend any sort of PEP. That would be secretions such as urine, nasal secretions, saliva, for example, even if it's exposed to mucosal membranes like the vagina, the penis, the rectum, etc. So, like saliva, we sometimes have patients that they had some sort of oral sex and they want a post-exposure prophylaxis. If they truly just had oral sex, the risk of acquiring HIV through saliva is essentially 0%. And so they wouldn't be recommended for any sort of PEP. It's also unnecessary if you know the person that assaulted them or that they had sex with is HIV negative, which is kind of obvious, right? Because they wouldn't be able to get it. In terms of the initial workup for someone that's coming in and being considered for PEP, so there's a number of tests they should get. They should obviously be tested for HIV, but also tested for every sexually transmitted infection, because they were potentially exposed to all of them simultaneously. They should also be tested for pregnancy if they are someone capable of having pregnancy. We often check chemistries and liver function tests, mainly because some of the medications we're going to use could be slightly nephrotoxic or have to be dosed differently if they have kidney dysfunction or liver dysfunction. That's not very common, but something to be aware of. And then hepatitis B and C are often recommended to be tested, as they can also be less commonly, but transmitted through sexual contact, and are important things to diagnose, obviously, and treat quickly. I'll share these slides later because there's a lot of text here, but essentially what this is saying is that for gonorrhea, chlamydia, and syphilis, sometimes you would consider empiric treatment, even if the test is negative, if you had a high concern that the sexual encounter was positive. So an example of this would be someone coming into the clinic because they heard that someone they had sex with 2 days ago has syphilis. We'll test them for syphilis, but we also give them penicillin. We don't wait for the syphilis test to come back. That's just because the risk is so great. In terms of the PEP treatment, so there's a number of regimens available. The most common regimens are, the most common regimen, I should say, is Truvada plus dolutegravir. And that's really the key difference between PrEP and PEP. So as you recall, with PrEP, we would use just Truvada, which is just one part of the treatment for HIV. If someone was exposed to HIV not on PrEP, we consider them to be at high enough risk of infection that we actually give them a treatment regimen. Like this is the same type of regimen we would use if we were actually treating someone for HIV infection. So it's tenofovir with the emtricitabine in the Truvada plus dolutegravir, which is the brand name is Tivicay. That is an integrase inhibitor, kind of similar to the cabotegravir, as the name would suggest. It's one tablet of each of those medications once daily for 4 weeks. There's a number of alternative medications that are used kind of off-label for PEP that are sometimes preferred. So, for example, using Descovy and dolutegravir, again, one tablet of each for 4 weeks, presumably as effective. It's just that different type of tenofovir. Probably not going to, no amount of tenofovir is going to cause any side effect over 4 weeks, but some people just prefer the newer formulation. It probably makes a little difference. Additionally, some people use Biktarvy, which is the most popular HIV medication now, because it's a single tablet and it combines the integrase inhibitor with the Truvada essentially. And so it's a single tablet regimen, and that is also probably effective for people, or certainly effective. It kind of depends on formulary issues and what the patient has for insurance, essentially. So that moves us into the second to last piece of this presentation, which is patient assistance for PrEP and PEP. Because certainly there are patients that are going to want to be on this and maybe not have insurance or be underinsured. So we're going to go through each of the medications. So for Truvada and Descovy, so again, these are the tenofovir emtricitabine combination pills. If someone has no insurance, they can actually be enrolled in what's called the Gilead PAP, or the Payment Assistance Program. A provider can do this application for the patient by either calling that number or filling out the form online at gileadadvancingaccess.com. Gilead is the manufacturer of both Truvada and Descovy. The only really requirement is that they be less than 500% the federal poverty limit, and then they will cover it 100%. So it's pretty liberal, and most people that are uninsured will qualify for this. They notably have to not be candidates or qualify for things like Medicaid or something. They'll usually still cover in those cases, but then look for you to get the person on Medicaid if the person would qualify for Medicaid. Some people are underinsured or they have commercial insurance, and so they still have a significant out-of-pocket cost for the PrEP. This is becoming less and less common, but it does still happen occasionally, in which case Gilead has a similar program called CAP, which is the copay assistance program. You can also fill this out online or call the same number. What this does is cover up to $7,200 per year for those copay costs, which will usually cover the entire costs, and so is really helpful for people who are underinsured. It will not cover the clinic visits and the labs, however, so it's just something to think about. Depending on what their commercial insurance is, they could get a bill for HIV testing, for example, every 3 months. It's usually not a very high bill. It's usually not something we have a lot of problems with. Most insurances do actually cover that. So if someone has Medicaid or Maine Care here in Maine, fortunately that covers both Descovy and Truvada. Interestingly, they only cover Descovy without the prior auth and Truvada with the prior auth. So here in Maine, if someone has Maine Care, we just usually prescribe them Descovy. That's really all there is to say about Maine Care. It's probably the best insurance option of all of these to have in terms of medications. Where things get the most complicated, like usual, is Medicare. Medicare is obviously very complicated. Whether or not someone's Medicare will cover Truvada or Descovy depends on what type of Medicare package they have. So if they have straight Medicare Part B, that's the medical benefit as part of Medicare, As of a year ago, they moved Truvada and Descovy from Part D coverage or prescription drug coverage, which had cost sharing, into Part B, which has no cost sharing. So that means that patients on Medicare with straight Medicare Part B can actually get Truvada or Descovy at no cost, with no cost sharing, no donut hole, which is great. The only caveat is they have to fill the script at a specific Part B pharmacy, which is most pharmacies like CVS, Walgreens, Hannaford, etc. Um, but you can actually go on the Medicare website and search by the pharmacy NPI number and see if it's a Part B pharmacy. Otherwise, they may not cover it. For patients with Medicare Advantage plans, unfortunately, there's significant variability just because there's so many Medicare Advantage plans. Most Medicare Advantage plans will cover either Truvada or Descovy, assuming that that Medicare Advantage plan includes a prescription drug coverage plan. Some people have terrible Medicare Advantage plans that essentially have no prescription drug coverage, and then they can be left in the lurch for this, and that is a problem. Something to think about, I guess, when you're getting Medicare Advantage plans potentially. Um, Cabotegravir. So for people who are uninsured, similar to with Descovy and Truvada, Vive, which is the manufacturer of cabotegravir, has a patient assistance program. Again, similar requirements to Gilead. You have to be less than or equal to 500% the federal poverty limit, and there's an online application. If you're underinsured with commercial insurance, there's also a copay assistance program that provides a similar benefit. Unfortunately, cabotegravir is substantially more expensive, and so $7,500 per year usually will not cover the whole year's worth of injections. So that is a bit of an issue. So where this is helpful was it can sometimes cover the year's worth of provider administration in the office, which usually is less than $350. But if the person's insurance is just not very good and say doesn't cover any of the cabotegravir is like $4,000 a shot. And so you're going to burn through that $7,500 pretty quickly. And that is one way that some people with commercial insurance are unable to get cabotegravir. But a lot of commercial insurances are covering this. Maine Care, again, kind of really great, covers cabotegravir without a prior auth, which is incredible. So again, the best place to be if you need PrEP in the state of Maine. Medicare, kind of similar with Truvada and Descovy, does cover cabotegravir under a Part B, so there would be no cost of sharing. It would be covered 100%. Again, it has to be dispensed from a Part B pharmacy, and then has to be administered in a doctor's office. Medicare Advantage plans, of course, vary. It depends on the Medicare Advantage plan, similar to Descovy and Truvada. For PEP, shifting gears a bit, there's a number of ways to get payment assistance. So people who are getting PEP because of sexual assault often qualify for assistance through various support organizations, such as Planned Parenthood, Maine Family Planning, the Office of Violence Against Women, which, despite the name, it's a federal branch that deals with sexual assault across the board, both men and women. So those are options. For occupational exposures, often all the testing and medication is paid for by the employer under workplace insurance or workers' comp, so usually that's not an issue. Maine Care, again, covers all PEP drugs, so if they didn't qualify for under sexual assault or occupational exposure, they usually can still get they can get coverage through Maine Care. Medicare, unfortunately, this is a little caveat. Although they cover PrEP under Part B, they cover the medications for PEP under Part D. And so that means that these are now subject to cost sharing, which can be a problem for some patients if they fall into the donut hole, or they have to pay usually about 20% co-insurance for the medications. Which would be more of an issue if you prescribe them something like Biktarvy, which is brand only, than if you prescribe them, say, generic Truvada and generic Tivicay. Something to think about. And then Medicare Advantage plans are, again, forever variable because it just depends on the exact plan. For people that don't have insurance or underinsured and don't fit into any of those prior boxes, Gilead has an advancing access program. Gilead makes the dolutegravir as well as the Truvada and Descovy. It's the same type of application as for PrEP. That's an option for people. So then the last portion of this talk, I'm going to go through this pretty quickly because I know we're running out of time. Vaccine preventable sexual transmitted infection. So like I said, it's important to have a multimodal strategy for sexual health, and that includes certain vaccines that can prevent infections due to sexual activity. One would be hepatitis B, of course. This is recommended for everyone nowadays. It's something that's given in infancy, but that was only since the 90s. So older patients probably don't have a history of vaccination in infancy. So it's still recommended additionally for sexually active people that are not in long-term mutually monogamous relationships, men who have sex with men, or quote, just those seeking protection, which is really vague. Um, Essentially, if you don't have a known or verifiable history of vaccination, you should vaccinate. And further notably, surface antibody testing is not a reliable test of immunity. This is a common pitfall among providers. They'll say a patient doesn't have a history of vaccination, so I'll get a surface antibody, and if it's negative, or they aren't vaccinated. That's not necessarily true because it wanes over time, whereas immunity is enduring. Um, so essentially, if someone thinks they had the vaccine, you don't need to test them for surface antibody. But if they don't know or they are sure they didn't, you shouldn't test anything. You should just vaccinate them. There's multiple vaccine options. The two older ones are the Recombavax and the Energex. These are made by Merck and GSK. These are 3-dose series at 0, 1, and 6 months, which is kind of a pain, as opposed to the newer Heplisav B, which is a 2-dose series at 0 and 1 month. So in some places, the Heplisav is preferred because it can be done so quickly. In 1 month, someone is immune essentially for life from hepatitis B. There's just some caveats. It can't be used in pregnancy, and it's not been established to be safe in dialysis patients. And then there's the Twinrix, which we should mention, which is a combo vaccine. It vaccinates both against hepatitis A and B. It is also a 3-dose series. It's something to consider for someone that is not immune to either, and you want to get them immune. The next STI is hepatitis A, which might surprise some of you that don't think hepatitis A is a sexually transmitted infection because it's often thought of as a foodborne infection, which it definitely can be, but it's also significantly associated with men who have sex with men, particularly people with receptive anal sex or anal cunnilingus or anal oral. People experiencing homelessness and people who use drugs. There's been significant outbreaks of hepatitis A in those populations, and so it's recommended that they all get vaccinated as well. This is again something that infants nowadays get as of about 10 years ago. So many patients that are adults now wouldn't have this. So it's a good thing to think about. There's multiple options. Usually the one we use in Maine Health, but it's really not, and it doesn't really matter, is the Havrix. It's a 2-dose series, one at dose at time 0 and then one at 6 to 12 months. The Vacta is an alternative that's essentially the same, but has a little bit longer of a window for that second dose. And then the Twinrix that we discussed on the last slide can also be used to vaccinate against hepatitis A. It's also notable that a single dose of any of these vaccines, or the Havrix or the Vacta, not the Twinrix, are about 80 to 90% effective. And so in some situations where you have someone that's say homeless and you're not able to get them back in 6 to 12 months for that second dose, it's still worthwhile to give them a single dose because that's going to get them at least most of the protection, right? Last vaccine preventable STD we'll talk about is human papillomavirus, the classic one. So as probably most of you know, if you do any sort of pediatrics, all males and females now, it used to be just females, age 11 to 12 are recommended to get the human papilloma series. You can catch up on vaccination up to age 26 now. And the guidelines actually suggest that possibly people over the age of 27 could be vaccinated. The main concern here is that it's unclear if vaccination after initial infection provides significant benefit in terms of reducing the risk of oncological complications like cervical cancer, anal cancer, head and neck cancers, etc. But it's still technically possible. There's only one vaccine available in the United States. That's the Gardasil 9-valent vaccine. If this is given at someone at the age 9 to 14, which is when it's recommended, it's a 2-dose series at 0 and 6 to 12 months. But if they're over 15 or immunocompromised, you're doing the catch up later on in life, it's a 3-dose series at 0, 2, and 6. Something to think of. Oh, and there's actually one more vaccine, then we'll quit. Mpox, probably people have heard about. It's recommended for all MSM, transgender, non-binary people with a prior sexually transmitted infection, multiple partners, transactional sex, people that participate in orgies or large-scale sex gatherings, or really just essentially anyone that wants it. Prior smallpox vaccination is not necessarily protective, so we've revaccinate those people with the new Mpox vaccine. There's only one vaccine commercially available. That's the Jynneos. It's a two-dose series at essentially 0 and 1 month. Um, we don't use the ACAMP 2000 that maybe some people are familiar with. This is just delivered subcutaneously, which is unique. So it's not intramuscular injection, but it usually goes into the fat of the back of the arm. It can also be given intradermally, kind of like a EPD for tuberculosis, for a dose-sparing intervention because you use substantially less of the vaccine that way. There's limited locations to get the Mpox vaccine, so notably Portland Public Health, Greater Portland Health in Portland provide it, Sacopee Valley Health Center, Northern Light in Bangor, and then pretty much all of the Maine Health infectious disease clinics also offer Mpox vaccination. And with that, and pretty much right on time, I am done, and hopefully we have a few minutes just for questions, because I know that was a whirlwind of content.